In this module, I'd like to discuss the once monthly administration of a nitrogen-containing bisphosphonate ibandronate, because this represents a unique progression of our thinking in terms of treatment, from a daily to a weekly and to a monthly. So why is this indeed a novel concept? Well, because the thinking up to the time was that the osteoclast lifespan is 2 to 3 weeks, and therefore administering a drug on a monthly basis would not be effective and would allow new generation of bone resorbing cells, the osteoclast, to come into play, and you would undo all the good work that you had done in the first few weeks of administering a nitrogen-containing bisphosphonate. So indeed, this was a unique approach. And what I'd now like to do is to tell you how we developed this approach in order to achieve efficacy in the factors that are responsible for bone loss and causing fracture. So ibandronate, the nitrogen-containing bisphosphonate, was first used as a daily administration of 2.5 milligrams a day. And the pivotal trial was called the bone trial. And in this trial, the drug was given either as a daily or as a intermittent dosing, which is very complex, and because it was so complex, it was never ever launched. But the 2.5 milligrams a day compared to a placebo did show efficacy in reducing vertebral fractures by 52%. The study was not designed to show non-vertebral or hip fracture because the patients were not at high risk for such events. However, when they looked in a high risk group of patients who had a T-score of -3, they showed that this drug, ibandronate, was effective in a post-hoc analysis of reducing non-vertebral fractures by 69%. They also then looked at high-risk patients in a different fashion. They looked at patients who had osteoporosis and a history of a fracture in the previous 5 years, and again showed it was very effective in reducing non-vertebral fractures. However, as I'd mentioned previously, one of the huge obstacles or impediments to us as practicing clinicians treating this disease is how do we improve compliance with medication. And we had a lot of market research showing that if one could extend the dosing interval, that you would enhance the compliance and obviously have a better end result in terms of fracture efficacy. But the challenge was, how do you convert a daily to a monthly? Well, first of all, you've got to have good preclinical data. And I know we as clinicians tend to disregard a rat or a dog because it has no relevance to those of us who treat patients sitting in front of you every day. But it was important to achieve the pharmacokinetics and pharmacodynamics to show that it was possible to increase the dose and extend the dosing interval. We then also had other tools such as modeling or simulation, but to cut a long story short, the trials were instituted for ibandronate, giving this as a monthly formulation. But could we do a fracture trial? And let us say at the outset, a fracture trials these days are incredibly difficult and costly to do. But there were precedents that one could use surrogate markers. The surrogate markers of bone mineral density and markers of formation or resorption. And what were the precedents? The precedents were that when ibandronate converted from a daily to a weekly, it was allowed by the regulatory agencies, both here and in Europe, to use statistical non-inferiority or equivalency, comparing bone mineral density to the dose that achieved fracture efficacy to the dose that Ibandronate wanted to use for weekly administration. So they could convert from a 5 milligrams to a 35 milligrams using the surrogate markers, provided they fell within the boundaries of non-inferiority. Ibandronate had the same modus operandi. They went from a daily to a weekly, and now they've gone to a monthly, using this bridging strategy. And again, the bridging strategy was built on using surrogate markers, which we know are predictors of fracture, and using these surrogate markers from the pivotal trials, which gave them fracture reduction indications and showing non-inferiority with the surrogate markers. So using the precedent with the nitrogen-containing bisphosphonates, Ibandronate and Ibandronate, Ibandronate embarked upon a trial. And this trial was the mobile trial. And here we went from a 2.5 milligrams daily, which we knew reduced vertebral fractures, because after all, the regulatory agencies in the treatment of osteoporosis only require vertebral fracture reduction. And here we could go from using the 2.5 as the landmark to a monthly. And the monthly dose that was chosen was 150 milligrams. Now this is slightly different in terms of its administration from the weekly, because with the monthly Ibandronate, one has to wait after an overnight fast an hour, which is no big deal if you're only taking the drug once a month. But we had to have proof of concept that the once monthly would work. And the proof of concept was using the surrogate markers. And if you look at the BMD increases compared to the daily administration, Ibandronate is the only nitrogen-containing bisphosphonate which not only obeyed the statistical rule as required by regulatory agencies of non-inferiority, those boundaries, but actually was superior to the daily. So we now had proof that we could extend the dosing interval from a daily to a monthly. We now know that this trial, which was conducted over 2 years, we have a long-term extension over 3 years, and the message is that as long as you take the drug, you will achieve continued increases in bone mineral density. A head-to-head trial was done comparing the increases of BMD that one saw with Ibandronate once a week, because this was bridged, to the Ibandronate once monthly, and again in terms of cortical bone the results were similar. There was no difference. In terms of the patients taking the drug, the responder rate was similar. The spinal BMD, there was a statistical significant difference in terms of the percent, but in terms of T-score there was no significant difference. So yes, we had now achieved the task of, perhaps counterintuitively against osteoclast physiology, of extending the dosing interval for a nitrogen-containing bisphosphonate, an oral nitrogen-containing bisphosphonate, from a daily to a weekly to a monthly.